Post-term pregnancies. We define post-term pregnancy as any pregnancy that has extended to or beyond 42 weeks from the last menstrual period. We have a term of post-date that's used to describe any pregnancy between 40 and 42 weeks. The um, the risk of post-term pregnancy or the percentage of post-term pregnancies is critically dependent on accurate pregnancy dating in the first trimester. The prevalence of post-term pregnancies is highly dependent on local policies for induction, on preterm delivery rates, on complicated pregnancy rates. Local policies of induction, we know that in each we have multiple policies of inductions, the timing of induction. So if the policy is strict to 41 weeks to induce all patients at 41 weeks, the risk of post-term pregnancy will be very low. Also it is dependent on the preterm delivery rate. So in a specific population, if the preterm delivery rate is high, means that the post-term pregnancies will be low. It is also dependent on the complicated pregnancy rates. What that mean? That means the high-risk pregnancies or the complicated pregnancies will almost in all cases need earlier induction, in most of the time before 40 weeks. This means like in hypertensive disorder in pregnancy, like diabetes, controlled and uncontrolled chronic and gestational diabetes, some of placenta previas, some of placenta accreta spectrum. So these complicated pregnancy rates will need in most of the time early inductions, so this will reduce the rate of post-term pregnancies. In USA it's about 6%. Using first trimester scan for dating results in decreasing the rate of post-term pregnancies to 2%. Risk factors: primary gravida, previous post-term pregnancy, some genetic factors, male fetuses more likely to reach post-term, maternal obesity, fetal anencephaly is the traditional example of pregnancies that reaches the post-term. The longest pregnancies um, uh, is found in the anencephalic fetuses. Risks associated with post-term pregnancies: doubling in the perinatal mortality, asphyxia and meconium aspiration, fetal macrosomia. This leads to fetal injuries and maternal injuries, fetal dysmaturity or past-maturity syndrome. Post-maturity syndrome, it has some specific findings like intrauterine growth restriction, like abnormal skin on the fetus, oligohydramnios, abnormal fetal heart patterns, and so on. Risks to the mother: labor abnormalities, fetal distress, failure to progress, increased risk of fourth and third degree perineal tears because of the fetal macrosomia, increased risk of cesarean delivery even in spontaneous onset of labor in post-term. I mean, if the labor was started spontaneously in preterm labor, still we have an increased risk of cesarean delivery. Management: either we induce the labor, either we do membrane sweep, or we do a conservative management. This is the induction of labor is the preferred course of management. Most units induce labor from 41 weeks and onward. Strong evidence from meta-analysis to support reduced perinatal mortality morbidity, and cesarean section rates. So we do induction at 41 to reduce these things, and the induction of labor at 41 weeks is shown to be the most cost effective. Membrane sweep or stripping of the membrane can be done during vaginal exam. It can reduce the rate of post-term pregnancy and the need for induction of labor. Uh, we recommend to do the membrane sweep for primary gravidas at 40 weeks. So the number needed to treat is 1 in 8 in each in every 8 patients underwent membrane sweep. One of them will end up in labor in the next week. It reduces the percentage of patients going post-term from 40 to around 25%. The conservative management is reserved for women who decline induction of labor or have a contraindication for induction. Um, Optimal gestational age for beginning monitoring is unknown, but is usually after 41 to 42. So if we choose the conservative management, we should monitor the pregnancy by amniotic fluid volume and non-stress test every 2 to 3 days, starting from 40 weeks or 41 weeks. Monitoring should include, as we said, amniotic fluid volume and CTG, and we should do immediate delivery if these tools of assessment became abnormal. Um, Post-term pregnancy should be associated with continuous fetal heart monitoring because we have a greater risk of fetal distress and meconium aspiration. Um, we have no detectable differences in the long-term outcome of the babies that goes post-term, especially the IQ, the physical milestones, and the intercurrent illness. And thank you for your listening.